3 में हॉस्पिटल खोलेंगे, डॉक्टर नहीं है हमारे पास. So the focus I am trying to bring you here is that availability वैसे short है ही, accessibility, because below 30 bed, which are 40,000, they do not have tertiary care. Now, how do we make sure? Otherwise, patient has to travel 200 miles to come to the nearest tertiary care hospital. So solutions are there if we work on this statistics. This 30 to 100 bed वालों को थोड़ा सा you can maneuver them because they are closer to being, but below 30 bed are very, I will not say difficult lot, but this is a lot where we have to work on it. Anyway, this I think you already seen it because in the urban area ये पुरानी कहानी है. अभी हमारे बिहार के प्रेसिडेंट बैठे हुए हैं, डॉक्टर सत्यजीत सिंह यहाँ पर. तो मैं उनको स्टेटिस्टिक्स बताऊंगा कि आज से एग्जैक्टली 5 years बैक बिहार हैड 13 मेडिकल कॉलेजेस, 13, एंड तमिलनाडु दैट टाइम हैड 49. सेम कर्नाटका, सेम महाराष्ट्र, एंड यूपी वाज आल्सो, आई थिंक इस समय थे 41 थे. क्वेश्चन इज हाउ कम दीज स्टेट्स लाइक बिहार एंड यूपी, वाइल ये 5-6 सदर्न स्टेट ने पूरे मेडिकल कॉलेज खोल दिए. They were intelligent enough, take the land in the rural area, set up the 25 acres में उन्होंने hospital खोल दी, which Bihar did not do it, UP did not do it, even West Bengal did not do it, by the way. So I don't know what is that magic that these states lacked. So anyway, उसकी वजह से क्या हुआ कि आपके जितने भी बच्चे पढ़ने वाले थे बिहार के, वो गए तमिलनाडु में पढ़ने, बिहार वो बेंगलोर में पढ़ने गए, और आपके पास वापस नहीं आएंगे वो. They will not come back to बिहार. So this, अभी हमारे मदन गोपाल ने बॉम्बे में एक प्रेजेंटेशन दिया था, आप उस समय नहीं थे, तो मॉर्निंग में ही showed the rating of the states, and again obviously the बिहार, यूपी ये नीचे दिखाए, except one thing, that incremental improvement यूपी में ज्यादा दिखाया इस बार. I mean, so that means they are waking up now. So the issue here is that somewhere again the political at the central level, or even that time I will say MCI also, did not do any efforts to see that we make sure that people spend money on the ये जो है. तो ये anyway ये वो same चीज है. So now I think अभी हमारे पास थोड़ा और टाइम है, 10 minutes. See, now if you see this statistic which we have seen now here, now we have to understand one simple thing that Dr. Sharad has shown now. कितना आपने दिखाया? 93,000 डॉक्टर्स निकल रहे हैं अभी, something like that ना. Almost 1 lakh डॉक्टर्स अभी निकलेंगे, और जो पीजी सीट्स हैं वो अभी भी मेरे ख्याल से 45,000 है. ओके, तो प्रॉब्लम अभी भी है. ये 1 लाख आपने खा दिया कि एमबीबीएस डॉक्टर तो कुछ भी नहीं है. क्या आपने वर्ड यूज किया? सादा एमबीबीएस. ये नया वर्ड आज इन्होंने निकाला है, सादा एमबीबीएस. तो और इसको एक बार डॉक्टर देवी शेट्टी ने कहा था कि प्योर एमबीबीएस इज बट नॉट बेटर देन हाउसवाइफ, समथिंग लाइक दैट. नहीं, इट इज नॉट गुड. आई फील बैड अबाउट that when we use this kind of language, जो भी है, मतलब एमबीबीएस 5.5 साल लगाता है बच्चा, 5.5 साल, और इंजीनियर 4 साल लगा के और 70,000 की नौकरी पे आ जाता है. I think we have to be very passionate or sensitive on this issue. Where have we gone wrong? Professional college means एक बार 5.5 साल के बाद बच्चा निकला, he is ready to treat the patient. Why it has not happened? We are responsible for that. तो ये, and I don't know, all MCI बैठी हुई है, NMC बन गई है, ये all these issues, they should be very alive to this. And अभी भी यही होने वाला है कि 1 लाख आपने तो कर दिया सीट्स, पीजी सीट वही 50, फिर मारामारी होगी, वही लड़ाई होगी, again the same will keep on increasing every time. Why are we? That's why again simple solution is open more PGIs. Don't open MBBS more. Open 10-12 PGI in the country. Is there any problem? Sudhir, आप बताइए कोई. Will there? I think हमारे expert तो यहाँ बैठे हैं. Dr. Arun, I think he will sum it up in the end. Why can't we have PGIs so that we overcome this problem much otherwise ये 5.5 साल ये निकलेंगे फिर 3 साल ये करेंगे आई डोंट नो 10 साल के बाद जाके हमें थोड़ा बहुत कुछ मिलेगा. So the issue is here. Otherwise, we have to find now. Of course, DNB has come up, step किया है 2 साल के डिप्लोमा लॉन्च किया है. फेलोशिप को हम रिकॉग्नाइज नहीं कर रहे हैं. We can recognize the fellowship. So we have to treat it as a war now. Otherwise, I think tier 3 आपका सफर करता रहेगा and patient और IMA, IMR और MMR will continue to be bad. So solution I think is known to all of us. Somehow I think we have to press for it. So I think now I'll spend 5 more minutes just to show you that if these are the challenges, the opportunities I think which I have discussed is 100-bed hospital. इसके ऊपर discussion I told you. First is upgrade below 30 bedded, number 1. Number 2 solution which we gave to government was that you give single window clearance. Our hospital जिन्होंने बनाए हैं green hospital, उनको पता है कि 1-1 साल 1.5 साल लग जाता, तब भी पूरी क्लियरेंसेस नहीं मिलती हैं आपको हॉस्पिटल बनाने के लिए. सेकंड इज यू गिव द लोन एट 6% एग्रीकल्चर, आप दीजिए. नंबर 3 वी सेड इलेक्ट्रिसिटी, शॉकिंग, वी आर बीइंग चार्ज एट कमर्शियल रेट्स, यू चार्ज एट द इंडस्ट्री रेट्स. एंड लैंड ऑफ कोर्स पीपल आर नॉट रेडी टू get free, because वो free land का आप पकड़ जाएंगे. So we will pay for land, but at least give us these 3 things. Now क्या होगा, suppose there is a hospital in Delhi, good hospital, tier 3, I mean tertiary care. उसको कहा जाएगा 100 किलोमीटर दूर आप एक हॉस्पिटल बना दो. They will do it because doctors can be shared, some teleconsultation होगा, doctors can go. So big hospital, all 100 bed and above, big hospital, 200 beds, they will be easily able to set up the beds within the 100 kilometer covering tier 3 town. This is another simple solution other than upgrading the 30 bed or 50 bed hospital. So these are the 2 things which we have said. This one is of course my pet area. India can become supplier of healthcare workforce. Recently अभी NSDC ने मेरे को एक मेल भेजा के we want to nominate you as the advisor to NSDC International. मैंने कहा what is this NSDC International? They say we want to explore that how we can train people here and they can go abroad. मैंने कहा पहले इंडिया को तो पूरा करो. You see, unfortunately you can see this India, हमारे पास काउंसिल नहीं है अभी तक. अभी लास्ट ईयर बनी है काउंसिल, Allied Healthcare Workforce. I'm surprised. और एक चीज मैं आपको और बताऊंगा, which is I have told Dr. Vijay also that we have to together take this fight. We are so particular about doctor to be MD, so particular the nurse to be the BSc, general duty assistant, जो भी हमें लेबर कॉन्ट्रैक्टर देता है, आंख बंद करके हम उनको हॉस्पिटल में रख देते हैं. आई थिंक डॉक्टर अरुण अग्रवाल, दिस इज अ वेरी सीरियस इशू इन माय ओपिनियन, बिकॉज दे आर इक्वली पार्ट टू द पेशेंट सेफ्टी. नर्स जब चाय पीने जाती है तो उसको ही तो बोल के जाती है, अरे देख लेना मॉनिटर को एक बार. एंड आई थिंक वी आर डूइंग इट, एंड विदाउट वी हैव टू रेज दिस पॉइंट एट द नेशनल लेवल नाउ, दैट वी मस्ट मेक श्योर दैट दीज पीपल आर आल्सो क्विकली 3 महीने की ट्रेनिंग करो, 4 महीने की ट्रेनिंग करो, कुछ तो उनको करो आप. So something, this is where we have to be. Then other thing is medical technology. Of course, luckily we are doing some good work, and Kaho, particularly our own organization, is doing good work, and hopefully something will come out of it. How we make use of हॉस्पिटल. एक और मैं सजेशन दे रहा हूं आप सबको कि हर एक हॉस्पिटल को एक होम हेल्थ वर्टिकल बनाना है अपने यहाँ. डोंट डिपेंड ऑन द आउटसाइड दीज हेल्थ केयर ऑर्गेनाइजेशन, सॉरी होम हेल्थ वाली, उनके पास लेबर ही नहीं है, आदमी नहीं है भाई. आपका एक वर्टिकल होना चाहिए, स्पाइनल इंजरी सेंटर, होम हेल्थ वर्टिकल, अपोलो 40 जो भी है आपका. So you have 200 bed, create 50 bed more at the home. It is good solution, and people will rely more on that because this is being provided by a established, credible hospital. So this could be one of the way of overcoming shortage, as well as certain palliative care or different kind of जो patient है हमारे, उनको हम देख सकते हैं. So this is what actually can be the solution. बाकी finally restructuring of CGHS, we are working on it. Ayushman Bharat Digital Health Mission, ये I think will bring wonders I hope we can do it fast. And बाकी हेल्थ एंड वेलनेस सेंटर जो बन रहे हैं इंडिया में 1.5 लाख, वो भी अच्छा काम हो रहा है, बट प्रॉब्लम वही है कि वहाँ पे हम नर्स को ट्रेन करके उसको इंचार्ज बना रहे हैं. अच्छी बात है, डॉक्टर्स हमारे पास तो अभी नहीं है. सो आई थिंक दीज आर दी सर्टेन थिंग्स दैट अवेलेबिलिटी एंड एक्सेसिबिलिटी आर दी मेजर चैलेंजेस. अफोर्डेबिलिटी को मैं बाद में लाता हूँ, पहले तो अवेलेबल तो हो, एक्सेसिबल तो हो, तब जाके आप उसको अफोर्डेबल बनाइए. एंड फाइनली you have to bring quality, and that's why Dr. Vijay Agarwal can sum it up how he can bring quality into this.
Wonderful, sir, as always, so illuminating. The only things that I can try to, just take it further in a way. We talk about these issues of things not being in tier 2 town, tier 3 town, etc. First thing is, sir, we don't have district wise data coming to us. Every time we are talking about 1.5 patients per 1,000 bed, etc., I want to know what is it in each district. And this data needs to come. We need to know it. Every time, somebody will be speaking in a forum like this, some industrialist is listening, and all he does, he has the money, he says, all right, let me also open another hospital in Delhi because the number of beds are very less. He has no realization that the number of beds probably in Delhi will be about 6 or 7 per 1,000. So you are overkilling some places and you go away just about 100 kilometers, and it's a very different story. Because we are not having, sir, district wise data. In fact, we are not giving any importance to data. I think today also we probably do not know the exact number of whether 30 bed, 10 bed, 40 bed, 50 bed, 100 bed hospitals. Even in my own state, even in a district, I don't have this information. And it is, I think, shocking to say the least. And I do not know how to cajole whom to get all these enumerations done at the earliest. We need to know, because unless you have the data, you cannot even reach to those people for even sharing good practices. So that is one thing. And I think this data, and again, one day we were talking, let's say government has 1 lakh some odd wellness centers. And I think it's a huge, I would say, step that has been taken by the government. But the data of these centers should be transparent. And we should use the CSR activities, sir. We have a lot of industries who will be very happy to upgrade these wellness centers if there are any deficiencies. There are a lot of private people who are very happy to kind of collaborate with any wellness center to upgrade it. But the thing is that you need a little more transparency. We need much more openness that these are our wellness center. This is what our good centers are. These are what are the, we must do some kind of a gap analysis. Another thing I would say, which you touched in the towards the end, and I feel that if you want to bring about any change in the accessibility of healthcare, it can only be done by technology, nothing else but technology. It will keep on, you will reach almost nowhere if we are not going to adopt technology in a very aggressive way. Now again, when we say this is like one thing to my mind. Government should probably convert 50% of its workforce to do only telemedicine and reach out to every corner of this country. We keep on trying to talk about it is not possible for a government hospital or something. They have, I would say, a government hospital, some of them, they have excellent minds, they have excellent kind of resources, but they are being utilized for fewer number of people. They need to, for example, today, whether it is tele ICU, you cannot run tele ICU because let's say my general ICU, and if you tell that person to also look after another ICU, it is a disaster. You have to develop these tele ICU in standalone office like buildings where they are looking at monitors just like they are looking at patients. So that's how I would say that probably the then I totally agree, and I have been also talking about it for a long, long time that the government hospitals must show the expenses that they are making on a patient. And I do agree that one of the great reason for a perception, because you go anywhere today, and even let's say you go to any party, anything, and even a little, I would say, talk, and this sentence will definitely come. डॉक्टर साहब अब तो धंधा हो गया, प्रोफेशन प्रोफेशन तो आपका रह ही नहीं गया सर, अब नाउ एवरीथिंग हैज बिकम कमर्शियल. I'm not saying, and I don't know what is the genesis of this statement. All these people have been going to the same corporate hospitals. Majority of the time, they come back and say, yes, sir, they had good treatment. They were quite happy. However, the sentence gets added, sir, but because they have a feeling that probably some unnecessary investigations were done. I'll tell you, yes, definitely ethics is an issue. I will take an example. I would say I know, for example, an ex nursing home who did not have a EEG machine. You see their references for an EEG prior to them not having the EEG machine to after they have the EEG machine. After they have the EEG machine, after that you will find much more amount of references being generated for EEG. Now, not necessary that those EEGs were not needed. It could also be that earlier he was not wanting to send the EEGs. So either way, there are ethical issues. Another problem is that we have no control, for example, that how many MRI scans can come up within a geographical area. Even in a country like United States, there is a regulation that you cannot have, for example, a particular modality of investigation which can be just not any number, because when you have that kind of number, then for them to economically survive, they are again depending upon the so-called referral practices, cut practices, and things of that kind. So somewhere along the line, I think we have to also, the government needs to look at some of these things, that how do we control a unnecessary proliferation of these things. We have to try and bring, I would say, indigenous our manufactured devices to the country to make healthcare affordable. One of the great reasons, I would say, is the non-availability of reliable medical equipments which have to be somehow brought in. Today, we are saying make in India, and to become, I would say, Atmanirbhar, we have to do something more, that these medical devices are being brought. I think, in fact, lot of government steps which they have taken are extremely good. They are fantastic. Somehow I feel that people who are now close to the government need to tell them that they need to walk the talk. They need to now throw also money into, show into the budget that they have made it from 1.2% to 2.5 or 3%. Not only on paper. The money needs to be there for them to spend on those schemes. And I think this will be a great, great way to make healthcare affordable and accessible. Dr. Mongo, over to you, sir.
Thank you, sir. Thank you. I think before we, uh, ask for comments, I know Samina. The issue is we have been talking about Ayushman Bharat. We have talked about the costing, and you will remember those days when it was being introduced and we were fighting the Niti Aayog and Government of Health and Family Welfare. You know, all these people were there. Do you have any idea that, government will boast of so many million people having been treated in 1 year? How many of them are going to private? How many of them are going to government? Number one. How much money is going to the private sector? How much money is going to the government sector? Because I have an issue here that government was already spending on government sector. They were giving money to them to run their hospital. And on top of it, in Ayushman Bharat, they are getting the money. And in private sector, they expect 8,000 rupees for a delivery, whether it is cesarean or normal delivery. or even lesser for a gallbladder surgery. So, and then on top of it, in some states like Delhi or Bengal or Kerala, it is, I mean, they have not taken it on a political ground. This issue has, this scheme has not been, taken up by them. Maybe they have other schemes also. Do you have any data about these private and government?
Yeah, we have. The data is available. But this discussion that why are you paying to the government hospital? Their issue was though actually the money which we are paying. Actually, that time they were stupidly frank enough to say that this is not a total money which we are giving. Actually, this money in a way will get into the development of the district hospital, and some honorarium will go to the doctors and the team. So, but they also realized that the cost given was really not the total reimbursement of the cost, but still they thought, let us give this money to our government hospital on this ground. But remaining the data, I can share with you that how much patients have gone to government hospital, how many to the private, and how much money has been given. This money, this data is available with us. I'll share
Yeah,
with you.
it was totally because they did not have enough providers to join the scheme, so therefore they could naturally tell the government hospitals to join. And now, if you really look at it, I'm just saying now, think in a disruptive way. This was the best opportunity to make every government hospital almost into a kind of a private setup. If you really cover 50 crore people of this country, tell me who is walking into that hospital who should not be covered. So either he is covered by this scheme, or he should be covered by CGHS, ECHS, or something. And let us say, of the people who are not covered, you can come out with something that the employer must cover that person, so that anybody who is walking into the government hospital, if he is going to be paid, then people will start expecting the kind of services that you start expecting from a private sector. So this was the best way, probably. Just this is what happened in Singapore. Let me tell you, Singh Health Singapore was a government, totally government-run institutions like this, and this is how they covered it. That by totally subsidizing the poor population, they'll give them free of cost, but the rest of everybody is paying.
Yeah. Thank you so much for this very nice session. And I must give you a big hand, and I think everybody should give a big hand. It's a very nice session. Number one, there are lot many critical issues. Why the doctors, are reluctant to attend a patient who is coming from CGHS, who is coming from ESI, because they say the compensation is not at par with what we earn. You see, because I've seen both the sectors. Let me tell you that I've seen the government sector, and now I'm seeing that from the other perspective also. That is one thing which we have to address. So that means either the rates need revision, or you see, we have to look from the other perspective. The pandemic has brought out enough, kind of about the shortage of resources. So somewhere I think we need to address the issue of guild of associations, which under the initiative has been created. That means we need to work horizontally and address, because you see, we had ventilators, we had so many emergency equipments, but people did not know how to use it. Kind of, it's not that we were always short of. So somewhere these issues, accessible healthcare, when we talk also, these issues also need to be addressed. Third is from the point of curriculum, when we are talking of, is the need of increase in postgraduate seats proportionate to, or it commensurates with the demand. We have increased anesthesia seats, but now the students don't join anatomy, they don't join physiology. So somewhere, all this also has to be worked out. And if we look at the competency of Indian medical graduate, which has been highlighted, now the same has been repeated for family medicine. So if our Indian medical graduate is so very strong, so, and we need to, and we were proud of the fact that this is one thing which is very important, and this is where the skill and competencies, they need to be brought in. And now I think next should be a good a good a step forward, but we need to kind of look at in this direction. Some of my
So my honest request to you all is that also we are looking into the education for the nursing. Of late, when we are receiving nurses, they have not even seen a patient. So, especially the ones coming, I don't feel bad to redress. It's coming from Bangalore, passing from Ragus, and it's very pathetic because when they don't know anything, gallbladder किधर है करके बोलेंगे तो इधर बताते हैं. So it is so absurd that if this girl doesn't know what is how you should do your palpation, where you should see auscultation, 4 quadrants कहाँ पे आते हैं पता नहीं है, femoral कहाँ पे होता है पता नहीं. So this is also going to create a lot of problem for nursing, because 90% of the time the nurses are looking after the patient. So we need to be very firm about this, and quality and infection control should be put into the syllabus right from this first year only, because without that I think we are crippled. Because today okay, but in bhavishya mein to, when we want to recover the rates from the patient, and the patient is not at all happy with the nursing profession or the nursing professional who's looking after, they are all wearing the uniforms. Some of them who have not even got an ANM degree or not even an ANM certificate, they are doing better nursing care than the one who's coming after a GNM and a BSc. BSc तो घर में बैठ के in the state of Kerala and appearing for the exam at Bangalore, coming to work in Mumbai, they don't take, of course, but in places like Gujarat and internal Gujarat, where I come from, a tertiary hospital, it becomes mess for me to whether I should take. So then my thing goes on, like continuously we are training and training. The minute they get their wings, they are flying from there or they become the best. So somewhere I want NABH and Kaho, if you all can work together over this.
Susan, totally agree with you, and that our medical graduates as well as the nursing people need to be job ready.
Yes. Thank you. Thank you so much.
Dr. Chabra.
Sir, once again, I would want to compliment the organizers and you for taking up such an important issue. If we were to summarize, I think there are limited resources. And if there are limited resources, there are two strategies then. One, judicious use of resources, and two, pooling of resources. But when it comes to judicious use of resources, do we have a structure to the health system in the country? So if you look at the apex tertiary institute of the country, AIMS, if you look into the outpatient, what are the number of patients seen in the outpatients which can be managed in the periphery, right? And what are the number of patients which can be only managed there? If we just look into that, maybe we may need less specialists than what is being forecast, because most of them can be managed in the periphery. So we need to build a structure in the country, and that is what I think we have not delved enough of. Grading of centers so that all of them are in the grade and they get centers only as per the need for that center. So two, if we look into pooling of resources, fine. So it is well accepted that the government can't work again. There has to be public-private partnership. So the government has done a huge task of trying to reimburse to the private centers as per the case mix, right? Like the DRG elsewhere. So why can't the same, what is the difference between a private and a government hospital? Let the government hospitals also be paid as per the scheme that the government has. So there will be efficiency which will come in. You will have judicious use of resources. You will have pooling of resources. I think if we get these two things, we will have a lot of the questions being answered and the healthcare problem being solved to a certain extent.
Very well said, Dr. Chabra, but my feeling is that probably before this data needs to be in place, unless I don't even know who the centers are, who the patients are, who the providers are. So I'm just saying, let's start building the healthcare ecosystem by creating a very structured thing, and then the structure will come out. You are absolutely right. Very well said. So I think,
Final remarks.
because we have to now.
One, I completely agree with this lady here and what Dr. Chabra is saying. I think we need to strengthen the nursing thing. I support the idea of IMP completely. Independent nurse practitioner is an idea that's waiting for too long to be implemented. But more importantly, two biggest of these stalwarts in the country are here about that. Uh, the issue of what you were saying, Vijay sir, government hospitals becoming like private hospitals. And I recall, Runa Durwal sir will remember, that time we used to interact a lot with Shilaji and Valia sir. I remember saying to Shilaji and Valia sir, both from IBAS, and said, look, and I'm sharing this as a thought, if it will convey. I never wanted, and I'm glad we did not convert the old mental hospital to IBAS as a private sector looking hospital, not anatomy. My focus was not anatomy of the hospital. My focus was physiology of the hospital. And unfortunately, when you say we want to convert government hospitals to private hospitals, the focus ends up being on the anatomy. The focus should be on the physiology of government hospitals being like private hospitals. वो हो जाए. And which, that's why I'm saying through both of you.
I sir, totally agree that in the sense I would say any private hospital which is spending huge amount just to increase its anatomy is doing a disservice to itself because it is not going to regenerate the money. You don't require Italian marble to treat patients. Quota is good enough.
So with this, we wrap up this session, and that's so nice of you, sir. Thank you very much, Dr. Vijay and Dr. Kisagani. Oh. Thank you, sir. Thank you very much. With this, we come to the final part of the program, this program, in fact. COVID challenges and the way forward. It's a big issue in the last around 2 years and 3-4 months that we have witnessed COVID in India. I mean, a lot of things have come up. In fact, all over the world, if you talk about it, then we'll see that, I mean, most research papers in the minimum time vaccinations, all these things have come up. And I believe that India has done a great job in this. But there are few challenges with us. So I'll invite the panelists to the dais. Please come here. We have 1 hour to go in this session. And first in the list is Dr. Sunila Garg, professor of GM Medicine. She's a member of Lancet Commission. She is a member of COVID India Task Force. That you must have seen her on TV on a daily basis while we were talking about COVID. COVID India Task Force and advisor ICMR. She is the chair of Program Advisory Committee, National Government of India Health and Family Planning, and then co-chairperson of multidisciplinary unit of ICMR also. Lead OMAG associate as a president during COVID times, published 250 articles and delivered around 300 media talks. So please welcome, ma'am. Welcome, you are here. I'll now invite Dr. Nimesh Desai. डॉक्टर देसाई के बारे में वैसे कुछ कहने की जरूरत नहीं, सब एवरीबॉडी इज रेफरिंग टू हिम बिकॉज he is a top psychiatrist of the country, published many articles and magazines and everything. And he has been the director of EBAS for the longest time, I believe. And he is here. I mean, we are lucky to have him here. I'll again invite Dr. Sharad Agrawal, the chairman of Hospital Board of India, to the dais. चेयर 2 चेयर और बोला था यार, 2-3 चेयर और यहीं से उठा लो यार. We are joined by Dr. Rajiv Sood. He is the top urologist of the country, having been the president of Urology Society of India and RML Hospital. I mean, he is serving RML Hospital for the last many years. Graduate from Maulana Azad Medical College in Delhi. He has been the dean in RML Hospital. We are lucky to have Dr. Chabra also with us. Please come over here. Dr. Chabra is the MD of Indian Spinal Injury Center in Delhi. He is with a 30 years experience in his field. And we are lucky to have you also here. And finally, and I think most importantly, Dr. Arun Agrawal, sir, please come here. एक चेयर नहीं नहीं ऐसे नहीं होगा, ऐसे नहीं. एक चेयर होते थोड़ा ये बात में चेयर एक चेयर होता. Dr. Arun Agrawal needs no introduction. I have no words to introduce him. We have seen him as a teacher, as a professor of ENT in Maulana Azad Medical College, dean for many years, then served Apollo Hospital and many other hospitals in the highest capacity, and in any field of healthcare, he is our teacher, our boss, and we are definitely blessed with your kind presence here, sir. Thank you, sir. Uh, I think to start, I'll request Dr. Sunila to talk about the journey we have had.
So I've got a little presentation.
Please come over. Let's talk about the journey in the last 200 quarter year or so, because she is the person who was involved in making some certain programs of the country and a guide to Niti Aayog and Government of Health also. So I'll request Dr. Sunila to go forward. Thank
Thank
you.
you so much. Actually, हाँ जी, जैसे भी।
डॉक्टर मोंगा प्रेजेंटेशन दिख रहा है
Good evening, everyone. And I'm sure basically it's a quick presentation to just, so that we know where we are. And we know that last few days also are creating, a lot of questions in mind of people as to we are expecting a fourth wave, though we know that we are progressing towards endemicity. But let me tell you, first of all, coronavirus is a novel virus, right? And all of us have been caught unaware, number one. In COVID-19 science, no one is expert, so we are not. Lot of things are beyond our understanding and without explanations. So we are learning every day new things. What we are expressing here is based on science, experience, and conviction. Any suggestion and critique should be taken with constructive manner. None of the models has worked on a sustainable basis. We talked that Bhilwara model worked, Dharavi model worked. They all worked in their own way. Kerala was a success story, done all along the way. Concept of herd immunity is notional. We said we will vaccinate all, but then we had the concept of natural immunity and all that. That is important to remember. India has faced third wave, three waves, second being the most severe, and the third wave was Omicron driven. No conflict of interest whatsoever, which I'm going to present. We all know that now we are talking of 1.4 billion population with male is to female ratio of 1000 is to 943. Rural urban divide is 65 is to 35. In the tribal population is 100 is to 8.6, and our internet connectivity is to the tune of 40%. Now you see, as Dr. Monga pointed out about the journey, we all know that first case came in on 30th of March, and quickly we started screening, for all the international flight passengers on 4th March. WHO declares pandemic on 11th March. Then social distance advisory was issued, basically on social distancing, closure, heightened travel restrictions was issued on 17th of March. And then another thing is we had countrywide lockdown. Basically we had on 25th of March, but before that we had Janta curfew on 22nd of March. So these are some of the important milestones, and this is accordingly we had increasing number of cases. By 29th of March you could see that we had 1024 cases. So, and then also side by side we had lot of kind of education material percolating around with regard to COVID appropriate behavior. So this picture is not unknown to everyone. I'll skip it, and these pictures are also not unknown to people. Now let me tell you, as of today, India stands second in number of cases. We have had 4.3 crore cases with total deaths 5,23,869. Total recovered are 4.25 crores. Still, we have 19,657 active cases, and 698 are seriously critical cases. And total 1 million population case per million population cases are 30,668, and deaths per million population are 373. That is where everybody is kind of questioning as to India ne deaths छुपाई हैं, India ने ये क्या है. So that is where we have to kind of look at it very, very critically, and we have to look at from the district wise. Showing pictures in media of Delhi or Mumbai does not reflect the actual number of deaths what have, because we know that the pandemic was confined mostly to the metro. So that is important part we have to remember. Another thing which I would like to say, I told you about three waves. Remember, India is 2 in total number of cases. India is number 3 in total number of deaths. India is 160th. Please remember the point number 9 in weekly change of cases, and 112th in weekly change in death. So this is where, when we talk of in terms of, and India is basically, when we talk of, look at the point number 6, it is also 118th in COVID tests per million. So that is also, we have to see that, this is where the government, tried to do that, but we could not match in terms of number of tests. So what were the principles of, our planning? Health system strengthening, developing surge capacity. Some hospital increased to the tune of 50%, some to the tune of 100%, particularly maximum during the second wave. And we had an intersectoral response plan also. And then our, strategies for tackling the impending third wave were prevention. That was the overarching thing. That's why I always say that public health perspective is very, very important in any program, and ensuring appropriate care to all categories of COVID patients, reducing mortality to less than 1%. And we also increased our healthcare capacity so that, and we could mitigate this pandemic and we could flatten the curve. So that is important. So active cases declined with the increase in our healthcare capacity increase also. So these were our strategic pillars against the government work: governance and coordination, promoting COVID appropriate behavior. We had lot of community engagement, containing transmission through surveillance, quarantine, isolation. Vaccination is a big success story, and everybody says that we started from 16 January, but we started working on it from April onwards. So the year we had the pandemic, we started, working on that. Then we worked on infrastructure preparedness expansion, human resources availability and capacity building, strengthening supply and logistic chain, enhancing quality of care, addressing challenges, and research and knowledge sharing. And my dear friends, in last 2 years, the number of publications which have come, the number of, press notes, the media notes and all that, they have been amazing. And those of you who have gone across the world will remember how India has progressed ahead. And then, we also had, for strategy for third wave was, we were very scared of, the villages and all that. So we had Maro Gam, Corona Mukt Gam. So that is where, we had that word. We had command and control systems across all the districts. We had to sustain and strengthen our existing infra in terms of beds, emergency units, pediatric testing, because second wave also focused upon, pointed towards children. And standby arrangements of ready to go hospitals also was there. Another thing which created havoc was availability of oxygen. So augmentation of oxygen supply and ventilatory support, maintaining strategic stock of essential COVID therapeutics, augmentation of human resources. This is what was being discussed in the previous session, and which I brought about the concept of guild and also skilled manpower, strengthening telemedicine, strengthening Dhanvantri and Sanjeevani, and strengthening of post-COVID, sequelae. This is now, I'm also part of several studies which we are looking at, immediate COVID complications, late COVID and late COVID complications. So recommendation is to have post-COVID clinics in every district. So Government of India is closely worked with Ministry of Health and Family Welfare, NCDC, ICMR, and National Disaster Management Authority. And those of you who are not aware of, we have also started, webinar series, and 5 webinar series have, been done by CDC India office along with National Centers for Disease Control and National Disaster Management Authority. I myself was involved in the 4th one. And Organized Medicine Guild, of which I'm also the president, is having 15 professional associations. So they are also a partner to it. So, we were doing the surveillance of international passengers, community surveillance, providing data to Ministry of Health and Family Welfare. And another very, very important thing is we started with genomic surveillance, though very late, but we started with that because Delta variant, though found in Amravati, was detected in UK. You can imagine that, it's just, very close to us. And then, Omicron found in Africa and all. But why do these, variants come in? So that is another point of concern. So today we can boast of, I'm talking of 1st May, 1.88 billion vaccination using digital mapping. That is important. And for all the years we have started, and now we have got the vaccine approval for children, 5 years and above also. So that is important. And most important part is that, and these are the number of, vaccination age wise what we have done. So almost, we'll say from the country's perspective, 95% of the eligibles have been given first dose, more than, 85% second dose. But it is 12 to 14 years have, been done less. But, more concern is in the parents as well. But remember, there is no exchange between the development and the vaccination. So this is where we have to address the fear part. And these are the 4 vaccines which all of they have become part and parcel of our life: Covishield, Covaxin, Sputnik, Corbevax. So this is there, and Zycovid D has already got the approval. Across the world, we are using 37 vaccines. So that is important. We have to remember, and everyone knows about, this electronic vaccine intelligence network, which is a success story on which we built our COVID platform. So it was not difficult for India, kind of to build this, because we already have a very strong immunization program for the children. So from the manufacturers till the last consumer, you see, we know that, it goes to the government medical stores and all that. And then plus, how this COVID app also provides the beneficiary acknowledgement, gives a unique ID, QR based certificate, and also we have a provision for adverse events following immunization reporting. So all these are components of our COVID app, and this is one of the biggest success stories, and it can accommodate even more than 30 countries' data also, as Prime Minister has had the meeting with different international experts. Another thing, everybody shouted during second this thing about the oxygen shortage. So now we have got a OxyCare app, so we know that in every district how much is the oxygen facility which is available through this integrated portal for oxygen managing devices. And also, we started with telemedicine care. We have got EduSat, India's first symmetric satellite dedicated exclusively to the educational services. And then we see it caters to wide range of interactive educational service delivery models like one-way TV broadcast, video conferencing, computer conferencing, or web-based conferencing. So, my take-home message is that, looking at the ripples of cases, expect COVID-19 to be there with us for few years as an endemic, and learn to live with it. Future waves and their impact will be governed by whom? They will be governed, number one, by people's behavior, extent of previous infection, percentage, speed of vaccination, and variants of concern. That is important. So PPPV. No perfect anti-COVID treatment, because we all saw remdesivir not effective, plasma not effective. That is important. So you see, no perfect anti-COVID treatment. Mainstay remains the symptomatic treatment, steroids only when required. COVID-19 has humbled all of us and made us proactive. That is important. Several things remain unpredictable and need out-of-box thinking. Disaster management plan and global health security should be in place. We can never completely understand the enemy, so keep open your minded pursuit. Herd immunity needs to be redefined and revisited. Vaccine wastage is criminal. Have not only media talks in terms of domestic vaccine, thinks about international vaccine method, because we are safe when world is safe. We are talking of one world and one way health. India is a classical example of how adversary can be converted into opportunity, and how beggary can be converted into donors. So that's how so much of supplies went from India. Vaccination in children is not easy. Start vaccination clinic. That is where I'm talking of. Standalone practitioners have got a very important role to play in terms of vaccination. Bridge trials to find faster boosters, lowering the dose of vaccination so that we can give partial doses. So this is important. And under this, we did one of the most successful webinars, Organized Medicine Academic Guild. That is, we talked of unwavering COVID-19. And, we had 12,214 doctors who attended this webinar. So this created a history. Let me tell you this. So we do not learn from experience, my dear friends. We learn from reflecting on the experience. So that is my own, experience from all of you. So thank you so much. So be the change what you want to see
Thank
in
you,
the
Dr.
world.
Neelagar. You're right that we have learned so many things over this period of time. And, when it started, Dr. Neelagar will agree that we had only one Pune laboratory doing virology. Now we have 5,000. We were importing PPE kits. Now we are exporting these. We had shortage of gloves, we had shortage of sanitizers, and everything was in short supply. But definitely this challenge has been taken up, and I think successfully taken up. We have Dr. Rajiv Sood with us. He was looking after one of the biggest COVID centers in Delhi at least, and they had a lot of issues. So I'll request Dr. Rajiv to talk about the challenges government hospitals had on those days. Dr. Rajiv Sood, is from RML Hospital in Delhi.
Thank you, Dr. Monga, for this wonderful webinar and inviting me in this. Uh, it was beginning was quite informative, and we all have freshened our memories and data and what all is happening in the scenario, at least in India, in relation to global scenario. I was in RML hospital. You know that this was the first hospital where the first case came and also the first death happened. And immediately the ministry was so shaken after that it was immediately flashed and a order was passed that immediately fixed the responsibility. How in viral infection a death can happen, so you can imagine after that there was agitation and also doctors represented that how we are going to treat the patients, and after that this all happened. The rest is the story. That order was of course withdrawn within 24 hours, and doctors were given. Then there was a meeting, and after that COVID guidelines. Now coming to COVID guidelines, which we are following now. I think every day or every alternate day, COVID guidelines were changing. So we were not knowing what we are doing. We were reading we were going for Google. We were going for the guidelines that what is to be done. Treatment, as has been mentioned, nobody knew that what is the treatment. Somebody is saying chloroquine, somebody is saying ivermectin, somebody is saying that put everybody on a ventilator. This was happening in the hospital. That ventilator should be and import as many ventilators possible. Then immediately the situation came that if you go on ventilator, you will not come out. So don't go on a ventilator. Then patients were in ICU bed, but ventilators were not put. I'll share that in the initial phase when we faced these patients, we were not knowing how to pack the patient, what instructions are to be done, how to hand over the body. So we were totally initially when we were asked in the health ministry, we were called the heads of all the institution. I was dean of RML and also looking after the COVID management, and also the from Lady Harding and LNJP, all the heads have come and instructions, every day instructions were given. Now tomorrow onward you start doing this. And for 2.5 months we were doing in that atmosphere RT-PCR. RT-PCR, only one machine was there in RMN, and you can imagine that how many cases we can diagnose or we can put to test. And our head of the microbiology, now she is the dean, Dr. Nandini. She was day and night working only to manage how to give the RT-PCR report. And this was so bad situation. You cannot test the patient. You everybody looked at, and there was a in March. You have mentioned that 13 March is it was declared pandemic, and 1 month before, 10 of the Supreme Court judges suffered from dengue. So people were totally confused. What is more serious at that point, and there was no treatment. And after 3 months, 2.5 months, including me, all the head of the institutions were in hospital. They were hospitalized themselves. I was there. You must be knowing in ICU for twice, and as has been mentioned that plasma here, plasma, first I was in the first trial. It was given to me, the plasma, and the plasma therapy, but nobody knew that when to give. Remdesivir also, that no cure, and then Ebola drug, remdesivir, that work was done in US. My daughter is the in charge of that section in San Francisco, and she told that I'll manage to get remdesivir. I'm very thankful to the then health minister and ICMR and also DCGI Within, I was actually hospitalized. Remdesivir was approved, but everybody was giving in the terminal care. Later on, we came to know that a virus is multiplying in the initial phase and it should be given as early as possible. Plasma also, the antibodies, later on it is no use. Early if you give, then it is important. So in that all chaos, people were very passionate. All the doctors who were involved, hospitals were empty, and infrastructure, the PP kits were not available. Even for the doctors, the N95 masks were not available. So as Dr. Monga has mentioned that how we started and how where we reached, as from beggars we have become the donors. So that situation is really commendable. As we say, we are number two in the world in as far as COVID cases are there. But I will tell that we are not even number two. We are quite low. Why? Because in US, what is the population? We are 6 times more than them, and their area where they are spread, we are crowded. It is very difficult for our social distancing. How you will do the social distancing in Indian conditions? So we are 6 times smaller in size as well as the area is concerned, and 6 times more in the population. So the factor is of 36. And if we, in spite of so much adversary in our population, distribution, and all, we have done wonderfully well, and all the doctors were so they were alerted, and everything was wonderfully managed. Now coming to the infrastructure and manpower. Manpower was really short. Infrastructure, wherever our ventilators were there, people were not knowing how to use them because we were given immediately for each bed. The beds were also donated by somebody. The ventilators were also given, but how to operate them, nobody was knowing. So you need the manpower for that, and you know that at any given time in the government sector, not in the private, there are vacancies of 30 to 40% and unfilled, and who will do the job? So there were so many adversaries in that we were working, and coming to Dr. Nimesh will be touching that. But I know after getting 2 rooms, one for me, one for my wife, and one for see, 4 and 5 or other family members at home, even servant having COVID. And in that situation, I was begging that you at least keep me and my wife in the same room. They told that you are entitled for single rooms. Like, I want in the same room, and you can understand how much mental agony was there, and it was very difficult that people, doctors were not. I'm telling, doctors are everywhere. They were doing wonderful job, but everybody was hesitating in coming to your near your bed and amongst you in spite of working so hard. It is a hard fact, and it was very difficult. People were talking to you on your mobile phones and seeing your condition on mobile phones. So this is also a fact. We should not underestimate that. And this was a situation when RML, we are handling dengue, chikungunya, your this H1N1, everything is coming, and we were very happy that happily declaring that don't worry, we will control everything. This is the first wave where all the adversaries were there. Thank God we passed that point time, and ultimately in the second wave, I need not to explain what all happened. There was a shortage of oxygen. You are telling that oxygen arrangements are there. You know that total supply of oxygen in Delhi was no less than the demand, and but the distribution was bad. There was no organized system how this oxygen will reach the people, And what has happened where distribution was good, that oxygen was also diverted to Delhi, and other places also suffered. So there was a lot of casualties, infrastructure problems, manpower problems, which gradually, by the third wave came, we have overcome. And when we are managing in our hospital, I'm giving the experience that we are feeling very comfortable now. What is happening? Omicron, it was milder disease. It was light, but I'll share at the end that in Omicron third wave,
I
it was
think, Dr. Rajiv,
milder.
we will have this topic with the other panelists also.
So, yeah.
We have to close it down by 6:30. That is what the
Okay.
organizers are saying. Thank
So
you.
I'm closing with that we are in the last sentence, that fourth wave, we are not scared at all in the hospitals.
Good, 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 good. All credit to people like you that we are sitting here today. Uh, Dr. Sharad is, looking after a 200-bedded private hospital, Lee Crest Hospital in Ghaziabad. Uh, in a few minutes, tell us your experiences. That was that challenge different, or we were sailing in the same boat?
See, as Dr. Sood tells that in the first wave, nobody knows what to do, how to do. Everything was new to everyone, and fear factor was very much there. See, you will be agree with me that by the time the second wave ends, the fear factor goes down. And in initial, I'm remembering that 160 GSM PP kit was recommended, and in the that hot weather, it was very troublesome for the doctors and the staff. And by the time second waves come, we have come to the gowns 40 GSM. So I come to the private hospital like in UP. Uh, lacking of beds was there, and no hospital was out of fear ready to convert it to a COVID hospital, except one or two hospital, and which were allowed both they were treating both the patient, private as well as the COVID patient. And UP government was very much apprehensive that whether they should allow it or not, because there is huge confusion around that. Then, as a UP IMA leadership, I wrote a letter to Chief Minister and requested him that why don't you are searching the beds, so why don't you allow all those hospital? I think in each and every city there are one or two hospitals which are ready to open, and just not opening because of the lacking of some statutory compliances and all. So we requested them that why don't you allow them to at least treat the COVID? And luckily, my hospital was the first hospital in UP which was allowed by the UP government to be the dedicated paid COVID hospital that time with 60 critical care beds. And that time we were catering entire UP because the pressure was only in the NCR, Delhi, Noida, and the Ghaziabad. They were the maximum hated who were treating the entire country that time. Because in the if you go to the in UP, hardly there were any knowledge or any willingness to treat, and lot of fear is there. So that is the challenge was to get the staff for a new hospital, to get the staff. That was the biggest challenge that time with us, how to get the staff, because they were not ready. The mindset was if we remain live after COVID, we'll earn. But that time they wanted to be save themselves. So this was the biggest challenge. So motivating the people, giving them little bit higher salary, and but definitely, and the expectation of the families in the particularly in second wave in the private hospital. First wave, nobody was asking you any question. Whatever you are doing, you are doing. But by the second wave, they were more demanding, like it happened in the private hospital, and they wanted every minute or every hour the patient brief, which is I believe that it was not the case in the government, but it was the difference between the government and the private, though the problem and the risk is the same with the government doctor and staff and the private doctor staff. So that is the challenge, but I am happy that we could stand up those occasions and we could serve. and we could did something, some contribution to the society.
Thank you. Thank you, Dr. Sharad. In fact, if people in Delhi remember that during the height of oxygen issues, uh, High Court passed an order for PSA to be put up in small hospitals also. And another part of it was that the oxygen requirement per bed in general ward and the ICU, it was calculated so exorbitant that it is very difficult to fulfill that even now. So we have Dr. Sehgal with us. Naren, you can come here, please. I mean, and he's working on that issue. So I'll give him 2 minutes to talk about both the issues and how this oxygen supply issue, oxygen requirement issue can be taken up. You can come here. Yeah.
Thank you, Dr. Munga. I think this topic has been discussed very many times. We all know that certain unrealistic orders are passed by the government, maybe in a hurry or maybe ill researched, you can say, where I feel the private partners should also be allowed to be part of the committee where such decisions are taken. I think even now the expectation of the or the asking from the hospitals is 6 liters per bed per minute. This is what is being asked. And today, if I calculate, my hospital, a 100-bed hospital, is using only zero point 0.3 liters per minute per day per bed. This is what we are actually using. And I suggested that we should all analyze it by asking all the hospitals what is their oxygen requirement today and what was the maximum oxygen required at any point of time, even during COVID being one of those once in 100 times, once in 100 years situation. You cannot take that as a benchmark for everybody to be arranging that kind of oxygen. I think we were all made to buy PSAs at a cost of, see, I bought 250 liters per minute PSA at a cost of 40 lakhs, created space for that, and we run it unfortunately only 2 hours a week. That's because I want to see that it is running. Because the cost of running a PSA is so high. You consume so much of electricity that it costs many times more than what is the actual cost of oxygen. And this will actually make justice only when the oxygen requirement, oxygen demand is so high that you use and run the PSA 24 hours, which usually doesn't happen. PSA, when it starts, it takes 2 hours to warm up and actually start producing oxygen. And you can't be, running it only for certain point of time for certain part of the day. So unless and up till your calculation is based that you use a PSA of a certain quantity and you can run it for 24 hours and rest of it can be augmented by liquid oxygen, which is, I think, the right way to provide oxygen to the hospitals. So I think we need to work on this, and time is short. I can present a full data of what oxygen
You are
should be.
working already with Dr. Gyani,
Yeah.
and I'll request Dr. Sunila and Dr. Arun Agarwal. I mean, they can use their good offices to see to it that we are out of this gambit. I mean, this is a definitely atrocious situation.
I think more
Yeah.
more research needs to be
Yeah.
done on this.
Thank
and
you.
done.
Thank you, Naren.
Thank
You
you.
can join us here. Now coming to Dr. Chabra. COVID, post-COVID issues. Many hospitals, many consultants are reporting that, I mean, variety of post-COVID issues from head to toe. We are experiencing everything. Nimesh will talk about the post-COVID and the pre-COVID and everything on psychiatry, neuro issues. But Dr. Chabra, sir, please tell us, I mean, what type of cases you are seeing as a post-COVID issue? Because I mean, everybody is worried about it.
Yeah, I think that is a burning issue also to be discussed, because they say one thing which we may be underestimating, and COVID has taught us not to underestimate it. is the long-term issues which come with COVID. And we see all kinds of patients, including a huge aortic aneurysm who came uh, post-COVID vaccination because they said there was a rekindling of infection. So with abdominal pain presenting to us, to patients with encephalitis who have come to us post-COVID, to myocarditis and all kinds of patients which come. And they say this impact will come to know only subsequently, because that is going to be a long-term issue which will be handling for a very long term. We are all aware of people who have been very fit and who after COVID wanted to test their fitness and then had various myocardial issues also because they tried to test if they were fit enough again. So I think one thing which COVID has taught us is we need to not be complacent. We are, I don't know if we can say we are post-COVID, right? Um, the Omicron was a mild variant, but we don't know what the next variant will be like. So the initial projections, if we think about when COVID first started, right? So the estimates that we were given, if that were to come out true, we would have seen huge devastation in India. So why we didn't get it? Maybe the strains, we were lucky that the strains we got were not the most virulent ones, or as I say, India ka Bhagwan, सारे भगवानों से बहुत तगड़ा है. So maybe that was the reason, but we don't know what would be in store for us next. So I think I'll just briefly touch upon one other issue, the challenges that we were talking about. Again, repeating, if we have limited resources, we need to make judicious use of resources and we need to pool resources. And the resources which were especially limited or continue to be limited during COVID was human resource. And that's going to be limited now for a long time to come, nursing, technicians, etc. So I think one of the best ways to make judicious use of resources that we learned was have protocols. If we can have protocols for treatment, we had, though the mandate was to have a maximum of 160 COVID beds in our hospital, we went far beyond 195 and beyond COVID patients. So, and being a spinal injury center with only 2 medicine consultants in the whole hospital, right? We pooled all the human resource and everybody was looking after COVID patients just because we had protocols. A COVID patient comes, these signs and symptoms, do this. These signs and symptoms, do this. You do a risk stratification, right? And then you put your patients as per the risks so that the most at risk get the most specialist attention, right? And then, as was said before also, remove that fear of COVID from the human resource, right? So what we did was we took out all the data, and more than 80% of our staff who got COVID did not get it in the COVID areas. They got it out of the COVID areas. And that is documented in the literature also. And we had to cite that in all our regular meetings with the human resource. Please don't be afraid of COVID. I said the biggest factor which helped me come out of the fear of COVID was getting the COVID during the second wave. So at the peak of the wave, when I got the COVID, I needed to be on parenterals. I was hospitalized, but I immediately moved out of the hospital after the first day. I'm lucky to stay in Compass, and I was taking parenterals at home. And I started taking rounds in the COVID areas then, and that fear of COVID went away totally. So then that inculcated a lot of confidence amongst people also. So I think judicious use of resources during the COVID, planning well, having protocols, Those will go a long way in our being able to manage the COVID crisis. Let's not be complacent. The fourth wave may not be like the third wave. We have to be ready for the worst. And if we are ready for the worst, we should be able to tackle it. I still say India ka Bhagwan, sabse tagda Bhagwan hai. Because otherwise, if the predictions of the epidemiologists were to come true, but we never had a condition like France in India. We never had a condition like Italy in India. We never had a condition like US in India, even though we had the second most number of patients. But we still have to be ready for the worst so that we continue this way. Thank you.
Thank you. Thank you. Very good, Dr. Chabra. In fact, the world was saying we should have 50 lakh deaths, that was a prediction. So we are here. You know, during first and second wave, there was so much of panic in our minds. Before getting an infection, so much of anxiety, lockdown, nowhere to go, no work to do. And then if you have it, then another type of apprehension. Will I survive? Will I not survive? Will I get oxygen? Will I get remdesivir? Or if I require, I'll get plasma or not. All these issues were there. And then after you have recovered, still people are having sleepless nights. They are so anxious about it. They are not able to work. So many psychosomatic issues are there. So I mean, we have Nimesh Desai sir to talk about these issues. I think this is the most pertinent part nowadays. Every psychiatrist has almost double the number of patients pre-COVID and now. Uh, Dr. Desai sir.
Thank you, Monga sir. Uh, I will, those of us who we have interacted, I anyway tend to speak rapidly. I'm going to speak much more rapidly now because I'm going to cover a lot of ground. But I must sincerely say, Dr. Monga, Sharad and Vinay first session, Gyani ji and Vijay second session, and this session particularly, all four panelists have been so great, so much learning. I'm going to try and summarize a lot of things. As a medical clinician, psychiatrist, as a hospital manager, as a trained public health professional, and as a policy guy who oversaw the private sector in mental health and across the country. Uh, so, Ministry of Health, NDMA, NHRC, whatever we could all see. But let me first recall, if I may, and I am almost certain we will all agree. And at the end of this session, not because I am saying this, but if we all feel, we must applaud what I'm going to share as a phenomenon. A little over 20 years ago, when I spent a year at Johns Hopkins School of Public Health as part of the Fulbright Fellowship Program, where not only the fellowship program had a lot of international participation, but the entire Hopkins community, as some of us will know, so international. And one of the Humphrey seminars, I remember distinctly ending the seminar talking about India and healthcare in India and the world, and say we in India would like to be world leaders for sure in the 21st century, but not the power broking world leaders, but the spiritual, substantive world leaders. And I've often in last 2 years thought, and I am now convinced delusionally. I am delusionally convinced that what many of us have done for 40 or 50 or 60 years has actually happened. It's not only going to happen, it's already happened. We are world leaders in terms of a whole lot of issues. And I think that's what I mean when I say that we really must applaud what we have achieved as a nation. I think there's a great deal to be proud of. If I might continue from there, why? The concept of resilience. And I just sharing this with you also last 2 years, we haven't really had much time to interact, but I've been saying this for last 2 years again in webinars. Besides the psychological resilience and the socio-cultural spiritual strength that we carry as Indians and South Asians, I think the physical immunity also helped quite a bit. Like I keep saying, वो जो गली कूचे पे गोलगप्पे खाने की आदत है ना 40, 50, 60 साल से, वो बड़ी काम आई है. I really do sincerely believe that physical immunity and psychological resilience, besides the management by the society and the government, was hugely helpful. But let me also say, and line with what Dr. Monga was asking, there is enough research in the last 25 years that we have ourselves been involved in. All disaster and conflict situations India and South Asia fare much better in terms of psychology and psychiatric disorders as compared to rest of the world. NDMA working groups we have that I coordinated, we have established this as a fact even before this epidemic. So we as a society do much better because of our socio-cultural spiritual strengths. And that I think stood one more time. Having said that, what Dr. Munga is saying is correct. Most psychiatrists, psychologists, and counselors have their hands full. Please let me clarify briefly. Mostly these are not new psychiatric cases. So there is no fear of new psychiatric cases except for acute stress disorder, very rare PTSD. What is happening is that most of you will remember mental health has had 80% service gap in this country and South Asia. So out of 100 individuals, if 10 are psychiatrically disordered, only 2 people reach any service. 8 people were not reaching anywhere. Now in these 2 years, most of those 8 people are coming out. So the hidden cases of the treatment gap are coming out, or the short-term acute stress disorder. And people with psychological distress. This brings me to my next point that I was talking with Dr. Vijay Agarwal just before this session. And this is one opportunity that we all have. The overlap between physical and mental health. You see, almost all medical and surgical conditions have a huge psychological and psychosocial overlap. We have failed, I admit, we in psychiatry have also failed in this country somehow to get it across to our medical colleagues and say, please forget schizophrenia. I'm not going to try and talk to you about schizophrenia. Clinical depression, perhaps, Dr. Munga or Dr. Sharad will see a few cases. But every case that they treat in their nursing home has psychological, psychosocial issues to be dealt with. And in this epidemic, like the HIV epidemic, you will agree, teaches us social, behavioral sciences and psychological issues to be important. Can we capitalize on that somehow? I'll take that a step further, my next point. World Bank and World Health report on DALIs and global burden of disease in the 90s began to prove that behavior is an important issue beyond psychiatry and clinical mental health. Accidents, self-injuries. But it stopped at the importance and relevance of behavior, ma'am, in NCDs. You see? So people like said, okay, not only clinical psychiatry, but NCDs, behavior is important. Now I dare say, go out on a limb and say, this epidemic has proven to us all health status is related to behavior. There is no part of health status of individuals or groups or societies that can be independent of behavior. And so we better start focusing on, is that my friend from Ahmedabad? Hi, Yogi. How nice. My 50 years old long friendship, how nice. So really, psychiatry, psychology, behavior, in fact, if I might say, I want to say this as a public health professional, Sunil might critically appraise. In last 20, 30 years, we had begun to know, although we didn't get it across to the society, that how my health status remains by at least I'm 35, 40 or 50 or 60 depends on how I behave and what my lifestyle is. Right? Importance of behavior in determining my health status. It was about individual. Your health will be like how you behave, my health will be how I behave, Mongaji's health will be how he behaves. Now, collective behavior is responsible for collective public health status. So the paradigm has gone 5 notches higher. So the responsibility of the society and communities to see that all of us behave well is, I think, one of the biggest lessons in this period. I will go back to what Dr. Sood and Dr. Chabra Sahab said. I am thrilled about what our friend said, sir, Dr. Sehgal. This is one in a, and like I said, I worked in hospital, government system. I know how it works. This was 1 in 100 years. Please, let's not plan our health infrastructure for next 50 years according to this experience. It will be the most stupid thing to do. Like Dr. Sehgal said so well, allow me to say also there that I have learned again from HIV field, Sunil will confirm, and from disability sector. Nothing about us without us. That policy, if the nation can follow, if you want to decide something about private hospitals, ask them. Don't sit in Nirman Bhavan and kind of, with all respect, issue dictation. Dictates happening, like Dr. Sood said, in the critical period was okay. The nation, the government, everybody was grappling. We didn't know what we were doing. We were doing whatever we thought best. Now is the time where we need to really become a little more participatory. Last point, sir. Post-COVID, one of my colleagues, yeah, Dr. Chabra said we can't say post-COVID. I agree. As a society, we are not post-COVID. But as individuals, many of us have been through the post-COVID era, and I really cut that part of the experience short. Like I think Dr. Chabra said, I happen to have been positive in the 2 weeks of the peak of the second wave. Fortunately, nothing at home. I had fun at home for 2 weeks by myself. So I've been through that experience. But clinically, now what I am saying is, first year I was based on our earlier experience and research. I wasn't very sure about psychological effects being very hard. I was convinced that resilience will take care of our Indian community. But I was wrong. I was willing to correct myself after the second wave and say there's a lot of trauma that people have gone through. There are psychological and psychiatric sequelae, maybe hidden, but they are there. Now I am really beginning to also realize that socio-economic factors and especially economic slowdown is affecting across classes. Forget again the labor class only, sir. In the upper strata or upper middle class, some sectors which have really suffered, there are cases of depression and suicide risk that all sectors of psychiatry now are seeing. So there is that thing of post-COVID that we all as medical clinicians and public health professionals need to be careful about. There again, I'll only go back to what Dr. Suniladi said. None of us knew 2 years ago what we were dealing with for that point of time, and Dr. Sood said that. Today, I don't think any one of us knows very well in a case that I see in my clinic, how do I differentiate how much of it was brain related post COVID toxicity, psychological issues, and depression, or something else related to the social economic factors? That learning, I really don't know, ma'am. आप या अग्रवाल साहब थोड़ा guide करें that how do we develop clinical paradigms so that we don't make mistakes in post-COVID assessment in any direction. Treat the person who deserves, because one danger, and I'll end with that, one danger we'll all agree, and this has been said for a long time in disaster situations. All psychotropics, especially benzodiazepines, go up. We don't want to do that also. Allow me to share, and with all respect to the pharma industry that we all depend on. Post World Trade Center collapse, the three pharma giants in the US trebled their budget for promoting tranquilizers. I hope you all register what I am saying. I can understand if the over the counter sales go up. I can understand if the prescriptions go up. People are scared. Promotion by pharma companies to say capitalize on human misery through sale of tranquilizers. So, with all respect to the pharma industry, I think we really need to be very careful about what I say is not over psychiatricize the post COVID. Don't use benzodiazepines and psychotropics where they are not required. Thank you.
Thank you. Thank you. Very, very lucid talk by you. Now we finally and most importantly come to our teacher of teachers, Dr. Arun Agrawal. The way forward. Where do we go home now today? And what is the message for us? Thank you, sir.
Thank you, Dr. Monga, all my friends, panelists in front of me, and my colleagues. They are listening to us carefully and so sincerely that I appreciate them. Well, we have heard all the expert comments, and I fully agree that Sunila, last 26 months, I can't comment upon the March 2020 till today. The worst were 3 months, April, May, June 2021. ये मैं मेंशन इसलिए कर रहा हूं जो आपने मेंशन किया उसके बाद लास्ट 26 महीने और बीच के 3 महीने इस पीरियड ने हमको बहुत कुछ सिखाया. एज ए मेडिकल डॉक्टर हमको ये भी बता दिया कि तुम कुछ नहीं जानते. हमने सबने एक किताब पढ़ी थी, हैरिसन, इंटरनल मेडिसिन. या तो वो फेल हो गई, हम फेल हो गए, ये देंगे, सब कुछ फेल हो गया, वापस कुछ समझ में नहीं आया। लेकिन क्या समझ में आया? दैट इज व्हाट डॉक्टर निमेश देसाई वांटेड। सुनीला जी, यू आर द पब्लिक हेल्थ पर्सन। 1918 में स्पेनिश फ्लू हुआ था, 2-3 साल चला था। इसका मतलब उस 1918 में जो इससे पहले इस टाइप का फ्लू, इस टाइप की प्रॉब्लम सोसाइटी के सामने आई थी, हमने उससे कुछ सीखा, लेकिन वो 1918 था। 1918 में हमारे पास रिसोर्सेज क्या थे, उस समय वहां पर कितनी मैन पावर थी, क्या टेक्नोलॉजी थी, हमको नहीं मालूम। थी, जरूर थी, लेकिन उसके अकॉर्डिंगली उन्होंने हमको कुछ इंफॉर्मेशन दी। वो इंफॉर्मेशन थ्रू डिफरेंट डिपार्टमेंट, मेनली डिपार्टमेंट ऑफ कम्युनिटी मेडिसिन हमारे सामने थी। हमने उसको थोड़ा समझा, थोड़ा नहीं समझा। लेकिन आज जब हम बात कर रहे हैं 2022 में, और हमने उतनी ही सफरिंग सही, उससे ज्यादा सही, इंडिया बिकेम ए सक्सेस स्टोरी। यहाँ पर डेथ कम हुई, हमारे चाहे गोलगप्पे खाने से हमारी इम्यूनिटी बढ़ी या कैसे बढ़ी मुझे नहीं मालूम, लेकिन कुछ हुआ जरूर, वंडर, कुछ वंडर हुआ। एक्सेप्ट दोस 3 मंथ्स, 3 मंथ्स में निमेश क्या हुआ इसका? तो मैं ये कहना चाहता हूँ, ये चैलेंज आप सबके लिए, इट इज नॉट ओनली द पैनलिस्ट, फॉर ईच वन ऑफ यू इन फ्रंट ऑफ मी, लेट अस put our thoughts together and make a document for future to learn. ये हमारे, अब पता नहीं इस समय फोर्थ वेव आएगी नहीं आएगी, हमें नहीं मालूम। डॉक्टर राजेश सूद ने कहा आएगी तो हम तैयार हैं, हम बिल्कुल तैयार हैं। हम सब दिल में जानते हैं कि आएगी तो माइल्ड आएगी, लेकिन ऊपर वाले ने तो हमको फेल कर दिया कहीं ना कहीं, किया है ना। तो इसका मतलब यह है कि हमको अपने एक्सपीरियंसेस इसके बेसिस पे ऐसे बनाने हैं, उसको इम्प्लीमेंट करना है फ्यूचर के लिए। इन सब एक्सपीरियंस को, एक हम अपनी ईगो को तो एक तरफ रखते हैं, ईगो को एक तरफ रख दें, एक कॉमन प्लेटफॉर्म पे हमको एक एक्सपीरियंस करके आगे का पाथवे बनाना है, एंड दैट इज व्हाट यू सेड। Whether it is a pathway for public health, it is a pathway for treatment, investigations, over medications, no medications. ये जो मैं 90 डेज की बात कर रहा हूँ, इसको मैं बहुत क्रिटिकली अपने आप भी एनालाइज करता हूँ, अपने फ्रेंड्स के साथ भी करता हूँ। 1 अप्रैल 2021 टू 30 जून अप्रोक्सीमेटली है मैंने, बट ये डार्क 3 मंथ्स मैं इसको कहता हूँ, डार्क 3 मंथ्स। इसको एनालाइज करना डॉक्टर विजय, चाहे आपका कहो, चाहे डॉक्टर ज्ञानी आपका एएसपीआई हो, डॉक्टर विनय आईएमए हो, कहीं पर भी हमको एक ऐसा डॉक्यूमेंट बना के देना है जो कि ये 100 साल नहीं, 200 साल के लिए, 300 साल के लिए एक लर्निंग लेसन बन जाए। वी हैव लर्नड ए लॉट। इसमें कई सारी हैरिसन बन गई हैं इस 2 साल में। तो इस चीज को हमको ध्यान देना है ताकि हमारे फ्यूचरिस्टिक जनरेशन दे डू नॉट सफर or they take enough precautions, because this is a learning resource for us. हमारे सामने बहुत बड़े चैलेंज आए। मैं अब भी कहता हूँ एज ईएनटी डॉक्टर, म्यूकरमाइकोसिस, विनय क्या हम सोच सकते थे म्यूकरमाइकोसिस का एपिडेमिक आएगा? अरे जब हम लोग स्टूडेंट थे, एक तो म्यूकरमाइकोसिस ईएनटी वाले ऑपरेट करते थे, कुछ और बढ़ गया तो आई वालों के पास चला गया। ये सब लर्निंग एक्सपीरियंस है। आप सबसे रिक्वेस्ट है कि कोई प्लेटफॉर्म बना के, आईएमए इज द बेस्ट प्लेटफॉर्म, एएचपीआई, इसको एक लर्निंग एक्सपीरियंस में हम लोग लेके आए। वंडरफुल एक्सपीरियंस डॉक्टर मोंगा, फॉर योर मॉडरेटरशिप एंड ऑल माय एक्सपर्ट्स एंड ऑल ऑफ यू, थैंक यू।
With this, I think We thank all of you also and our panelists, and in the morning also Dr. Girdhar Gyani, Dr. Vinay, Dr. uh, Vijay Agrawal, and Dr. Neela ma'am, Dr. Nimesh, Dr. Sharad, Dr. Rajiv, Dr. Chabra, and sir, finally to you, sir. Thank you very much. Thank you all. I think the organizers may want to declare some program for the night. I don't know. Which stay in auditorium. We will be moving from this, and we have award distribution there. Thank you all. Thank you all. We'll reassemble there. I'll request Dr. Vinay, Dr. Vijay, and Dr. Girdhar Gyani also to join us here. Dr. Naren, please come here. आइए सर आइए एक मिनट इकट्ठे सब
बड़ा फोटो Okay.
Thank you all. Thank you very much.
So 7 p.m. move to auditorium. Yeah, right now. Yeah, yeah. बढ़िया रहा ये डॉक्यूमेंट बन सकता है बहुत इंफॉर्मेशन है वी हैव प्लेंटी ऑफ ये लीड जहाँ देते कहाँ हैं, बोलेंगे तो भाग जाएंगे
मैं जब इसके आर्टिकल्स देखता हूँ पढ़ता हूँ मैं आई फील मैं कह सकता हूँ मैं इसका प्रेसिडेंट
कई